Hello people, in this video we want to look at this topic optic atrophy. You can also say optic nerve atrophy. So atrophy of the optic nerve. So what is optic nerve? It is behind the eyeball, right? You know that behind the eyeball, whoever is taking the information to the brain. Optic nerve, it's the second cranial nerve, isn't it? So this has some parts to it, and if you remember, you have seen this in the microscope, right? In histology. This is optic nerve, the way it looks under the microscope. And this is how it is hand drawn in the lab, optic nerve. So you can see it has the central vein, central artery, blood vessels in arachnoid matter. Then what is this? Pia matter, subarachnoid space, arachnoid matter, subdural space, dura matter. Nice, right? So this is how optic nerve looks. And these are the parts of the optic nerve. See here, you have intraocular, that is the disc. Intraocular is the disc. Then you have the intraorbital. Then you have the intracanalicular. Then you have the intracranial. So 4 parts looks like it has. Then what else? So basically we have looked at optic nerve. So what is atrophy? Atrophy is reduction in size, degeneration, right? So now you understood what it is. Optic nerve atrophy is the degeneration of the optic nerve. So where exactly are we? We are in the diseases of optic nerve. Okay, here we have seen so many diseases of the optic nerve. We have seen optic neuritis, congenital traumatic optic neuritis, toxic optic neuropathy, then ischemic neuropathy, papilloedema, tumors. Everything finally can lead to optic atrophy. Just remember that, okay? Finally, it will lead to what? Degeneration of the optic nerve, okay? So if optic nerve itself atrophy occurs, guys, then how will the vision? It will be like this. Yes, no vision. So optic atrophy, finally it will become zero vision, even sensation of light, kind of perception of light also. So optic nerve atrophy, you should know everything can result in this, okay? Based on this, okay, let's look at the definition of optic atrophy. Degeneration of the optic nerve, which occurs as an end result of any pathologic process that damages the axons in the anterior visual system, that is from the retinal ganglion cells to the lateral geniculate body. They are talking only about that part of it. So they are talking about the retina till where? Till the lateral geniculate body. Till here, if anything happens, that only they are terming as optic atrophy looks like. Let's read the sentence again. No, this optic atrophy is a result of that. Result of any pathologic process that damages what and all? Anything from the retinal ganglion cells till the lateral geniculate body, anything is damaged, that can lead to optic atrophy. That is what this is the pathologic process. This is the cause. From retinal ganglion cells till the lateral geniculate body, damage to the axons will result in what? Optic nerve atrophy, degeneration of optic nerve. Okay. So these are some images of optic nerve atrophy. We'll come to them. In this, there are some types. Okay. So let's look at those types. Very easy to remember. You have simple optic atrophy, that is starts at the optic nerve, optic disc, that itself is simple optic atrophy. Post neuritic optic atrophy is secondary, that is after neuritic optic neuritis, long standing neuritis will result in this, that will become post neuritic optic atrophy or secondary. Consecutive optic atrophy is not around this optic disc, somewhere like the retina choroid. If that is involved, because of that retina choroid, because of that it will be consecutive choroid. Okay, then you have glaucomatous. You have already studied this, raised intraocular pressure. It will put pressure and there will be cupping and all that. You know this, right? Glaucomatous is separate category they have put. Vascular, ischemic, because of any cause other than glaucoma, ischemic problems, it is causing optic atrophy. Did you get it? So lot of causes are there for optic atrophy. Primary means they are blaming some tumors like trauma, toxic, something that affects the optic disc directly, you can say. Secondary is long-standing cases of these optic neuritis, etc. Then consecutive, they are saying something because of the retina choroid, you can blame them, retina choroid, and then finally, let us say it's affecting here. Then you have glaucomatous, then finally they have written vascular, other than glaucoma, all the other ischemic causes they are putting there. Did you understand the classification? In the exam, they will ask you primary, secondary, they can ask consecutive also. You should know secondary is post-neuritic, okay? So now let us look at this primary versus secondary versus consecutive. They have a table here. So the appearance of the disc will be chalky white in this. In this it is dirty grey white, and consecutive they are saying it is waxy pallor. Margins are ill-defined in secondary, obscured lamina cribrosa in secondary, otherwise well-defined in both of these. Then coming to vessels, they are saying it is normal here, peri-papillary sheathing. Then in consecutive, they are using some word called attenuation, which seems to be like attenuation only. Surrounding retina is healthy, is hyaline bodies, drusen, pathology is seen here. See, in this, if you see the primary one, right, only chalky white appearance, otherwise everything is well defined, well seen, normal, healthy. You see, everything is fine except the first word. In secondary, almost everything is like, has something to it. Consecutive, because of retina and choroid, has some things to it, but not at least the margin or the lamina cribrosa. Okay, so did you understand, guys? Yeah, let's look forward. You may understand later. Primary is by primary, we already told you, it is lesions proximal to the optic disc without antecedent papilloedema. Some lesion proximal to the optic disc. So it didn't start with papilloedema and then this didn't come. This came initially itself. The lesion is near the optic disc itself. This is primary. So what and all can happen at the optic disc? Some multiple sclerosis, then hereditary optic atrophy, some intracranial tumor directly pressing on the anterior visual pathways like pituitary tumor, trauma, avulsion of the optic nerve. Just give a nice punch and the optic nerve will get avulsed directly. So primary optic atrophy. Toxic amblyopia. Here they are telling retrobulbar neuritis chronic. Here they are saying idiopathic. Tabes dorsalis where you are seeing neurosyphilis. Yes. Remember here it is all about the optic disc. All about the optic disc itself. Primary simple optic atrophy. Here what did we see in features? The color of the disc is chalky white. Are you able to see that in the image? Color of the disc is chalky white. Rest and all, nothing they are blaming. Everything is perfectly fine. They're not telling anything in this except that the color of the disc is chalky white or white with bluish hue. So this is optic atrophy, which is primary. Yes, it looks very white. Now let's move on to secondary. Secondary is post-neuritic optic atrophy. Okay. So as a sequel to long-standing papilloedema or papillitis. Papillitis is a type of optic neuritis, right? So long-standing papilloedema, papillitis, right? Because of that, you will develop post-neuritic optic atrophy or secondary optic atrophy. Remember, secondary is nothing but post-neuritic. Okay. Papilloedema will have what? Raised intracranial tension along with this edema of the optic disc or something. So in this case, there will be papilloedema. There will be more disc edema. Remember, okay. But as a long-standing case of all this, post-neuritic optic atrophy or secondary optic atrophy. If they ask you secondary, it is post-neuritic. Remember. So this is the image which shows. Let us look at the features. We have seen the features already. What does it look? Dirty white in color. Yes, it looks a little dirty. Due to gliosis, the edges are blurred. Main thing here is the edges should be blurred. Yes, edges are blurred due to gliosis. So it is trying to repair itself, but it is not able to repair kind of a thing. It's a long-standing condition, you can remember. What else are they telling here? The lamina cribrosa is not visible. Physiologic cup is obliterated. Everything is kind of negative in this, isn't it? Retinal vessels are attenuated. Perivascular sheathing is often present. So looks like everything is obliterated. Physiological cup obliterated. Lamina cribrosa not visible. Retinal vessels are attenuated. Okay, gliosis is there. Edges are blurred. Okay, let's move on, guys. So then we are moving on to consecutive optic atrophy. This is the third one we are learning, right? Consecutive optic atrophy. This is, like we told you, because of choroid or retina. Something happened to the choroid or retina, because of which now there is optic atrophy. So secondary to the degenerative or inflammatory lesions of the choroid or retina, because of that there is optic atrophy, consecutive optic atrophy. What are the causes? Here you have chorioretinitis, retinitis pigmentosa, then pathologic myopia, central retinal artery occlusion. Okay, so something with the retina and choroid, remember. So remember, one example is the retinitis pigmentosa. Here you can see the pigment, right? Retinitis pigmentosa. Let us look at the image here and try to understand the ophthalmoscopic appearance of the disc in consecutive optic atrophy. So first of all, optic atrophy. See here, the margins are again perfect, right? Here also the margins are perfect. You can see a lot of pigment, retinitis pigmentosa. What else are they seeing here? The disc appears waxy yellow. Sorry, yes, yellow waxy. Yes, yellow waxy. Where is that? In consecutive. Consecutive, like yellow waxy. The edges are not so sharply defined. Oh, I thought the edges are sharply defined, but not as sharp as primary. Okay. Retinal vessels are attenuated. Okay. So the edges are not as sharp as primary, but anyways, they are sharp. Let's look at the difference here again. So margins are well defined in primary and consecutive, but it's the most well defined looks like in primary. Okay, ill defined in secondary because of gliosis, and laminocribiosa you cannot see in secondary because of all this. So secondary has more problem. Peripapillary sheathing is there. Oh, so the sheathing is a bad thing. This peripapillary sheathing that you see in secondary. Go to secondary. Is this secondary? Yes, this is secondary. Secondary is nothing but post-neuritic. Perivascular sheathing is often present, is also a bad thing. Okay, so in secondary you have lot of issues. How's it going, people? So we have finished what and all? Primary, secondary, consecutive. Secondary is nothing but post-neuritic. In this, there will be dirty white. The margins are not clear. You cannot see the lamina cribrosa. Then you will see perivascular sheathing. Then the retinal vessels are attenuated, something like that. Then what else did we see? We saw that. That's it. That's it. Okay. Gliosis will be there. Gliosis, remember. Okay. So consecutive, we have finished. Retinitis pigmentosa, remember that is consecutive. Now let us go to the fourth one. Fourth one is glaucomatous optic atrophy. It results from what? Long-standing raised intraocular pressure. So in that we have already have a complete separate videos there on glaucomatous. What will happen in glaucomatous? There will be deep and wide cupping of the optic disc, right? Shift of the nasal shift of the blood vessels. Remember, all this we have seen in glaucoma video. So nasal shift of the blood vessels can happen. Wide, deep cup of optic disc. Okay. So this is showing the nasal shift of the blood vessels. If this is the right eye, this will be nasal and this will be temporal. So nasal shift, it looks like the vessels have shifted to the nasal side. We are done with the fourth type of optic atrophy. Now the last one, vascular ischemic. So other than glaucoma, they are talking about here, they are talking about severe anemia will cause ischemia. Let's say severe hemorrhage, giant cell arteritis, quinine poisoning. Remember, arteritis, hemorrhage, anemia, everything to do with blood, but they are not considering glaucoma here. So that will be vascular ischemic optic atrophy. Marked attenuation of the vessels will be there in this. Okay. Marked attenuation of the vessels. Do you see any marked attenuation of the vessels? Definitely the margins are not clear in this. But anyways, they are not talking about all those features. They are definitely saying marked attenuation of the vessels. Okay. So where are the margins not fine? In secondary, yes. So in exam, they will usually ask only these three: primary, secondary, consecutive. Learn the differences. Okay. Secondary is nothing but post-neuritic. Guys, there is one more type of classification: ascending and descending. Ascending or autograde, they are saying it is from the eyeball towards the geniculate body. So that is ascending. Ascending means what? From the eyeball to the geniculate body, that will be ascending. What is descending or retrograde? Descending or retrograde is from the region of the optic tract, optic chiasma, posterior portion of the optic nerve towards the optic disc. So retrograde will be towards the optic disc. Autograde will be from the eyeball. Okay. Autograde is from the eyeball. Retrograde is towards the optic disc. So from the eyeball means because of the retina and all, if it is Due to diseases of retina, we already told you. So that can be ascending, isn't it? See, beyond the lateral geniculate body, we are not considering here. Damage beyond the lateral geniculate body does not cause optic atrophy. Okay, so optic atrophy from where to where there's, so it can cause because of the eyeball till the lateral geniculate body, any damage here to the axons, etc., can lead to optic atrophy. So we are done with one more type of classification, ascending, descending. Now let's see what else is there remaining in this. Pathologic features. Degeneration of optic nerve fibers will be there with unsuccessful regeneration. It will try to regenerate these optic nerves which are getting damaged, but it is unsuccessful. So there will be proliferation of what? Astrocytes and glial tissue. Okay, so there can be degeneration and gliosis, which is very orderly. That will happen in primary. In primary, what will happen? Degeneration and gliosis, which is very orderly. Some longitudinal columns of astrocytes. See, astrocytes arrange themselves in longitudinal columns, replacing the nerve fibers. This is called as columnar gliosis. So in primary optic atrophy, what is happening? Orderly gliosis, right? Gliosis, which is very orderly. Then coming to post-neuritic, which is nothing but secondary and consecutive. Here you will see degeneration with excessive gliosis. In degeneration with excessive gliosis, they are talking about secondary and consecutive. Remember, in secondary, the margins were not fine because of the gliosis, right? That's what they blamed. So excessive gliosis is there in secondary. That is why the margins are not fine. Remember? Then negligible gliosis. That gliosis also is not happening. Why this gliosis or regeneration and all? Why it is not trying to repair? Because decrease in blood supply. So this can happen where and all in glaucomatous and ischemic or vascular. So this kind of makes sense, isn't it? So what will be the symptoms of a person who has optic atrophy? Loss of vision. So depending on whether it is sudden or gradual or partial or total or the degree, this person will have loss of vision, right? Loss of vision. Visual field, how will it be? See, in optic neuritis, you have seen central loss of vision will be then optic neuritis. But in glaucoma, you have studied that towards the end, that guy will have tubular vision, tunnel vision, isn't it? So depends on, you cannot, it's like these two are totally contrasting. Here he cannot see the center, here he can see only the center. So visual field loss will vary with the distribution of the fibers that have been damaged. So remember, in glaucoma it's more like a compression, right? So eccentric loss is there. But in optic neuritis, central loss, isn't it? Shall we put a loss word here? Central loss, like that shall we put? Or eccentric loss, like that shall we put? Peripheral vision is lost, isn't it, in glaucoma? Central vision will be retained with some temporal island. That's what we remember about glaucoma, isn't it? So you have looked at loss of vision. Guys, now let us look on to the signs that a doctor will elicit. Signs will be more like, what will you check in the pupil? The pupil is semi-dilated. Okay, the pupil is semi-dilated. Direct light reflex is very sluggish or absent. Swinging light, flashlight test depicts Marcus Gunn pupil or RAPD. What is RAPD, guys? It is called as relative afferent pupillary defect. RAPD is what? Relative afferent pupillary defect. Guys, this every word in this is so important. Okay, so pupillary defect, yes, it's afferent and it is relative to the other eye or something, is it? Let's see. But it's, every terminology is very important in this, okay, in this Marcus Gunn pupil or RAPD. So what will you see here? See, what did they say it is? Semi-dilated it will be. So here, when they are putting light to this one is also constructing, which is perfectly fine. So both of these, at least, wait. This one is fine. So this one also consensual light reflex is working. But now when you swing the light to the right eye, this right eye has some problem, that is RAPD positive it is. This right eye has problem, so it is not constricting. So left one also is not constricting. Okay. So this is, you just see some nice videos on this in YouTube. Relative afferent pupillary defect. Remember, it is afferent defect and it is relative. Sluggish or absent. Swinging flashlight you have to do. Okay. Look at this video on severe RAPD, guys. It's really nice. Constricted. The right one constricted initially. Constricted. But then now the right one is dilating. Constricted. Right one is dilating on light. Constricted. The right one is dilating on light. A nice video, no guys. Visit this link to see more. So what did you see that on giving light it is dilating, right? That is Marcus Gunn Pupil. That too it is relative. So you have to do swinging flashlight test. Okay. Ophthalmoscopic appearance of the disc, guys. Where are we? What are we looking at? Optic atrophy, ophthalmic fundus examination. We already saw. Primary, what will happen? Secondary, what will happen? Consecutive, what will happen? We already saw. What are they trying to say here? What is this? Decrease in the number of small blood vessels. Kastenbaum index, something they are telling. Decrease in the number of small blood vessels. Kastenbaum index. In general, they are saying what and all will be there. So this you may have to write for all of it, right? All the 5 things. Pallor of disc. Decrease in the number of small blood vessels. Some Kastenbaum index. The pallor is not due to atrophy of the nerve fibers, but due to loss of vasculature. There will be loss of vasculature. That's why there will be pallor. So other things we have described individually under primary, secondary, etc. Look at this and see if you can tell which is which. Margins fine, white disc, primary. Retinitis pigmentosa becomes what? Consecutive. So this is consecutive, yes. This one, the margins are not fine, obscure. Definitely this is secondary, isn't it? So this is post-neuritic. And what is this one? Ischemic, they are saying. How will you say this is ischemic? The vessels are some attenuated something, right? Only 2 more slides left. Differential diagnosis and treatment. So differential diagnosis, you should be able to differentiate primary, secondary, consecutive. Optic atrophy versus other causes of pale optic disc. So pale optic disc can happen because of other things also, like non-pathologic causes are there and pathologic causes are there. Non-pathologic causes, they are saying an axial myopia. So axial myopia to be kind of a stretched globe, isn't it? Infants, elderly people with sclerotic changes. So if they have sclerotic changes, it may look a little pale, right? Temporal pallor is associated with large physiological cup. So only if temporal pallor is there, right, there could be large physiological cup. Pathologic causes for pallor disc other than optic atrophy will be hypoplasia, congenital pit coloboma. Okay, so you should know the differential diagnosis in case they ask. Last one is treatment, guys. You have to treat the underlying cause. You know the causes now. It could be trauma, toxin, it should be tumor, it could be retinitis pigmentosa, it could be retina, choroid problems, it could be glaucoma, it could be vascular problems. So many problems now, now you can try to fix those problems. But once there is, complete atrophy, you cannot recover the vision. So that's all for now in this video on optic nerve atrophy. Hope you learned something. Hope you have learned something. Let's take a quick recap now. Very quick recap, guys. Don't worry. So optic nerve, you have understood it is second cranial nerve. Atrophy means degeneration. So this is a disease of optic nerve. After almost everything, finally it ends up in optic atrophy. Degeneration of the optic nerve, especially the damage to the axons from the retinal ganglion cells till the lateral geniculate body, that can result in optic atrophy. So there are many types of optic atrophy. Primary, simple optic atrophy, post-neuritic, secondary optic atrophy, consecutive because of retina or choroid, glaucomatous because of raised intraocular pressure, and vascular ischemic. 5 types. In primary, you saw it will be chalky white disc. Other than that, there is no problem. Secondary, you saw there will be dirty white and it will be ill-defined margin, lamina cribrosa. You cannot see. Everything is there in this, okay? Peripapillary sheathing, hyaline bodies, drusen, something. Consecutive, what is it? It is because of retina and choroid. Here, there will be waxy pallor, etc. So let's look at this. There are so many types, like we told you. Let us look at the primary one. Primary one, what will be there? Why is it called primary? Because the lesions are proximal to the optical disc. Optic disc. It is everything about the optic disc. Tumor, trauma, toxic amblyopia, multiple sclerosis. So anything, all about the optic disc itself. Chalky white disc, nothing else they have mentioned here. Okay. Post-neuritic is secondary. Here there will be long-standing papilloedema or papillitis. Because of that it will happen. Long-standing. Here remember the margins will not be fine. The lamina cribrosa you cannot see. Cup is obliterated. Gliosis will be there, because of which the edges are blurred. Dirty white. Dirty, remember secondary is dirty. Post-neuritic. Then retinal vessels are attenuated. Perivascular sheathing is often present. Coming to consecutive, you saw it is because of retinitis pigmentosa, etc. Basically, it's because of choroid and retina that this happens. So you can blame chorioretinitis, retinitis pigmentosa, occlusion of central retinal artery. Pathological myopia also they are blaming here. Okay, here how does it appear? The disc appears yellow, waxy. It is sharp margins compared to secondary, but it is not as sharp as primary. The retinal vessels are attenuated here. Glaucomatous you have seen because of raised intraocular pressure. Here there will be cupping of the disc and nasal shift of the blood vessel. Vascular you saw it is because of everything other than glaucoma, like giant cell arteritis, severe hemorrhage, severe anemia, quinine poisoning. Here what will you see? Pallor of optic disc. Like we said, you pallor of optic disc, you have to write for all the 5 things, okay? And marked attenuation of vessels you will write here. And the other thing they told you is decrease in the number of vessels will be there. That is called as some K something. What is that? Kastenbaum index, okay? So you have ascending and descending. Ascending means from the eyeball. Descending means towards the optic disc. Then pathological features you saw there can be gliosis, degeneration with gliosis. So there can be degeneration, gliosis if it is orderly columnar gliosis, it will be in primary. If it is excessive gliosis because of which the margins are not fine, that definitely you can say is secondary in or post-neuritic. Remember in consecutive, margins are not as obscure as secondary but not as perfect as primary. So this one is secondary, okay. Then in the other two, glaucoma and ischemic, there will be negligible gliosis because pressure, it's not getting blood supply. Then where will it create gliosis and all that? Symptoms, the person will have loss of vision, visual field, you saw there can be central loss, right? In optic neuritis, there can be tunnel vision in glaucoma. Coming to Marcus Gunn pupil, pupil is semi-dilated, direct light reflex is very sluggish, but when you swing the flashlight, you can see Marcus Gunn pupil. It is relative, afferent, pupillary defect, RAPD. The signs of the disc you already saw: decrease in number of small blood vessels, Kastenbaum index, pallor of disc. All these are very general. Then coming to differential, you should differentiate it from other types of pale discs. Pale disc can happen because of, let's say, axial myopia, elderly people who have sclerotic changes. It could be a large physiological cup itself. Hypoplasia, congenital plate coloboma could be pathological causes other than optic atrophy. Treat, what will you treat? Treat the underlying cause. Once complete atrophy is set in, you cannot recover the vision. That is the revision, optic nerve atrophy. Bye bye.